Thank you for joining us tonight for Relapse and MS. This series is brought to you by Mallinckrodt Pharmaceuticals. My name is Laura Allen, Programs Manager for Can Do MS. I will be your moderator this evening. Can Do MS delivers health and wellness education programs to help families with MS thrive. Please visit the Can Do MS website, cando-ms.org, to learn more about Can Do MS's online and nationwide in-person programs. Our speaker this evening is Megan Weigel. Megan is a nurse practitioner and has been practicing neurology for about 20 years, most of which has been focused on MS. She recently completed a fellowship in interactive medication at the University of Arizona and has launched her own practice, First Coast Integrative Medicine. Good evening, Megan.
Hi, Laura. Thanks so much for having me and for providing people with the opportunity to learn more about relapse and multiple sclerosis. We have some great objectives tonight, and I know that we will meet all of them. We're going to review historical and current classifications of MS, so basically the types of MS and how we speak about them. We will learn what a relapse is and how it differs from a pseudo-relapse. We'll try to understand the treatment options for both, describe the role played by the interdisciplinary team in symptom management of both relapses and pseudo-relapses, and then hopefully leave you with a toolkit that gives you realistic expectations for relapse outcomes. So the bottom line is when this discussion is over, you should be able to communicate effectively with your support partners and healthcare team about relapse, know what to expect and who to call, and have a plan should a relapse occur. I think that one of the best pieces of news that we have lately is that fewer people with relapsing MS are having relapses. And the reasons for that are twofold. One is that people are getting started on disease-modifying therapy much earlier in their disease. And the other is that our disease-modifying therapies may indeed be a little bit more effective in the modern era. So to start, I'd like to talk about classical types of MS. And these are the ways that we've talked about MS for as long as I've been in the field, which is just about 20 years, and longer, a few years longer than that. So most people have relapsing remitting multiple sclerosis. About 80 or 85% of people with MS have been noted to have this type of disease, and about 10 years after diagnosis, 50% of those people will become secondary progressive. And secondary progressive MS can also include relapses. However, after the relapse occurs, one doesn't go back to baseline. About 15% of people have primary progressive MS, and then a very small percentage of people, perhaps about 5%, have progressive relapsing MS. And so I think these types are fairly clear for most people, although no one likes to hear that they have transitioned, say, to a secondary progressive phase of the disease. And so for that and other reasons, clinicians and scientists started looking at how we could possibly redefine how we categorize types of MS that would help us in research, and that would also help us create a landscape that might be a little bit more fluid. For example, a person with progressive disease could have a period of time where they are active and a period of time where they are not active. So this is an example of one of the ways that MS has been defined now in 2013. And it's a comparative slide. So we're looking on the left-hand side where it says relapsing remitting disease, where we expect full recovery from relapses initially, and then may have some residual deficit after an incomplete recovery. So with today's language, what we could say is that relapsing remitting disease may be inactive or not active, which means no new MRI lesions, no relapses, no changes in disability, no increasing symptomatology over time, or active, which means any one of those categories. And you may have in a period of a year active relapsing remitting MS, and in a period of another year inactive relapsing remitting MS. And in the same way we speak about progressive disease. So progressive disease can be active or not active. But since tonight's talk is about relapses, we'll stick with relapsing forms of MS. Here are the basics of the disease, and I love to see that this statistic has changed finally after a number of years to reflect that way more people than we thought about before had MS. I don't like that that's the case, but I certainly do appreciate the fact that we realize how important it is for us to educate the general public about multiple sclerosis and also people living with the disease about the kind of help that's available to them. Women are 3 times more likely than men to have MS, like most autoimmune diseases. MS affects people living with MS as well as their families and friends, and it also affects your lifestyle, your dreams, and your goals. So it doesn't just affect, your physical body, your emotional or your thinking body, but it also affects some of the plans that you may have had for your life. And relapses can make that even more difficult to handle. MS is an autoimmune disease. It's a chronic disease that doesn't have a known cause, but it's thought to be related to an interplay of environmental and genetic factors. And you can say that perhaps in a person with MS, the perfect storm occurred. Things that we know are associated with MS are smoking, a high sodium intake, low vitamin D, and exposure to the Epstein-Barr virus. And actually, it's the most common non-traumatic cause of neurological disability in people of working age. Oftentimes, that disability is cognitive or from fatigue, not necessarily the physical part of the disease that take the person out of the workplace. MS is treated depending on the type. Treating relapses and symptoms are also important parts of the treatment paradigm. So not just modifying the disease with disease-modifying drugs, but also treating relapses and symptoms as they occur. MS symptoms can be visible and invisible, and I find among the people who I know who live with MS that the invisible symptoms are often the most challenging and the most disabling. Visible symptoms are quite clearly things that you might see, like problems walking, problems with coordination or balance, sensory issues, vision issues, mood changes can be visible. Invisible symptoms can be things like pain, fatigue, sexual dysfunction, bladder and or bowel problems. Again, vision issues may be invisible, cognitive problems, and mood changes. And some people might say, well, how can vision issues be visible and invisible? And I think that if people really have a hard time seeing, then they might need the assistance of someone to help assist their vision. From an invisible standpoint, people who have eye movement abnormalities oftentimes have difficulty processing patterns of carpet or flooring, and so this can be an invisible visual symptom. So how do you as a person living with MS navigate symptoms? I encourage people to do a daily survey, or sometimes I call it a daily body check. So when you get up out of bed, you've got some choices. You move around for a little bit. Maybe you take a sip of your coffee or tea or whatever you have in the morning. And after moving your body, feeling your body, taking an inventory of your mood, You might say, this feels like a good day, or maybe this feels like a mediocre day. Maybe I know this is a bad day. These are symptoms that are familiar to me, and they're working at a higher level against me than they usually are. Or what if this is a holy what is happening to me kind of day? What do you do when it's that kind of day? I think it's important to know what you would do on any kind of day, because that helps you manage your energy level, manage your expectations, manage your to-do list, manage your rest. But it's that fourth bullet, that, oh my goodness, what's happening to me kind of day, that leads us into relapse or pseudo-relapse. I am no longer surprised, but I was initially, when people living with MS are unsure of the things that constitute a relapse. I have had people tell me that they've had 10 to 15 relapses in a week. And when we really dive into the nitty-gritty of what happened with their symptoms, I help them to realize that indeed they weren't having 15 relapses. They were having fluctuations of symptoms that were causing bad days. So a relapse is quite a defined event, and it's a new neurologic symptom or increased severity of an old neurologic symptom that lasts more than 24 hours and that occurs more than 30 days from the last relapse. It cannot be explained by another cause, and that other cause might be another medical problem. It might be a pseudo-relapse if it's the recurrence of an old symptom. And especially as people living with MS enter an older age range as our population gets older, and may have other medical conditions like diabetes, high cholesterol, hypertension, obesity. If a new neurological symptom happens, I think we have to have a very low threshold for seeking help to find out what's going on. So we're going to talk about John. I hope that this example is helpful to you regarding how a relapse can show its face. John is 40 years old. He's been living with relapsing MS for 5 years. When he's tired or overheated, he usually experiences decreased color vision in his right eye. And years ago, with his diagnosis, he had an optic neuritis in his right eye. So what he experiences is something called Uthoff's phenomenon, and that's graying out of vision in an eye. It's like a reminder that your optic nerve doesn't quite work right. And when you cool down or when you rest, your vision goes back to the way it was before. One night after work, he went to bed with some tingling in his right arm. He'd never had it before. He'd had a really busy day at work. He was on the computer more than normal. He figured that, maybe his arm was tired from all of the work that he had to do. As the next day progressed, his right arm and leg became numb, not just tingling, and this was a new symptom for him. The next day, he called his neurologist because he said, you know what, this just is not right. This is one of those, oh my gosh, what's happening kind of days. Let's talk about what John's going to do as we go through what a pseudo-relapse is. A pseudo-relapse is an increase in severity of an old or recurring neurologic symptom. It's caused by infection, fever, exposure to heat, but also less commonly to cold, increased stress or fatigue. The most common infection to cause pseudo-relapse is urinary tract infection. And a UTI can cause an increase in MS symptoms even without traditional UTI symptoms like suprapubic pressure or frequency of urination or painful urination or bladder spasm. In this case, we'll talk about another case example. Mary is a 55-year-old who's been living with MS for 20 years. When she is tired, sick, or overheated or under a lot of stress, her leg spasms get worse and her legs tingle. Lately, she's noticed frequency of urination, and those symptoms have started to get a little bit worse. She worries because of these worsening symptoms that she's having a relapse and calls her doctor. He says, you know, Mary, you have these symptoms frequently when other things are happening in your life, and I think that we need to order a urinalysis. And so reluctantly, she agrees, but the urinalysis does come back positive for a UTI. She's treated with antibiotics, and her symptoms resolve very quickly once she starts the antibiotics. The reason she was reluctant to have a urinalysis is because I think the fear of relapse is very real, and the fear of what a relapse could potentially mean for a person is quite a large one. I would encourage you to take a look at the webinars available on the Can Do website about how relapse challenges affect a person in the home, at work, and with relationships. It's not just the challenges that having a relapse can cause in these environments, but it's also the worry of having a relapse. So I would definitely encourage you to take a look at those webinars. So how would we treat a relapse? The foundation of relapse treatment for relapsing MS is starting on disease-modifying therapy early. You can kind of think of that as the roots of the tree. And then assessing how that therapy is working for you and your MS on a regular basis and staying adherent to your treatment plan. Maintaining health with exercise, with healthy eating habits, and receiving regular preventive care to make sure that your other body systems are working at the level that they should. And also addressing emotional health. So you might say, well, does that really treat a relapse? And what we want to do is to do our best to prevent relapses from happening. And so that is the foundation of relapse treatment, is let's try really hard to keep ourselves healthy and well so that we're less likely to have a relapse. And if one does occur, we're much more likely to be able to handle it emotionally, physically, better than we otherwise would have. I'm sure if some of you are active in attending MS events or these webinars that you have seen this model before. This is Dr. Stephen Krieger's topographical model of MS and what he calls a dynamic visualization of the disease course. I love this model because I think it's helpful for people to understand why some things can show up and then go away. So if you look at the water level on the slide, and then I'm going to call them icebergs because that's what they remind me of. You look at the icebergs that are under the water and peeking through the water. You can think of those icebergs as symptoms that are apparent to you on a regular basis. And as we look at the red, yellow, and green moving across the screen, there are certain areas of the brain where we're more likely to see symptoms if lesions occur. And the optic nerve is one of those areas. The brainstem and the cerebellum is another area. And cerebral hemispheres are less likely to have a symptom show up in the body as lesions occur, just because the brain is so capable of using other parts to do important jobs. So let's go back to the water level. Now imagine that this water level is a representation of you having a good level of reserve. And by reserve, I mean you're well rested, your stress level is under control, you're eating healthfully. If you have diabetes or thyroid disease or high blood pressure or high cholesterol, those conditions are managed by a current treatment plan that includes not only possibly medication, but also those other important things like rest, exercise, and nutrition. And then let's imagine that it's the holidays, because we all just got through them. And even though the holidays are a very joyful time for most people, there's some stress involved. And that stress isn't necessarily anxiety, but it's just the go, 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 do that most of us do around the holidays. And so you're staying up late to get things done, to see family, to see friends, to go to parties. Maybe you're not thinking about hydration as much. You're not getting as much sleep. You're not moving your body as frequently because you have other things to do, like Christmas shop or Hanukkah shop or wrap presents or send out cards. So that water level that represents wellness actually starts to drop. And as it drops, those other little icebergs start to peak above the surface. They've been there all along, but they have not shown up in your body. So this model I find to be a very good example of pseudo-relapses, of good days and bad days of symptoms. These icebergs that represent lesions that are always around, but if you're taking good care of yourself, you can't notice them show up in your body in your daily life. And I hope that makes sense to you. So let's move on to relapse treatment. Relapse treatment involves one of these 4 medications most of the time. And I say most of the time because sometimes, depending on the severity of symptoms, in a conversation between an MS provider and a person living with MS, they may opt not to prescribe a steroidogenic treatment for whatever reason. And that reason may be tolerability, it may be convenience, it may be cost, it may be severity of symptoms. Know that your treatment of a relapse, so whether or not you decide to take a treatment for a relapse, does not affect outcomes of your MS 10, 20, 30 years down the road. So your relapse is going to do what it's going to do, whether you have treatment or not. If you have treatment, it's going to do what it's going to do faster. So you'll either get better faster, or maybe you have symptoms that don't completely resolve. The bottom line is that relapses cost you time. They may cost you money if you're working, and they certainly cost you worry. So most of the time, we do wish to treat steroids, and the most common thing we treat them with is IV steroids, and Solumedrol or methylprednisolone are the most common forms of IV steroids. We give them for 3 to 5 days, usually 1,000 milligrams. Challenge can be access, and by access I mean if you've had steroids a lot of times over your life, then maybe you have bad veins. By access, I also mean your literal ability to get them. With insurance changes over the years, it is much more difficult for people to receive IV steroids in the home, which means many people are having to go to an infusion center to receive IV steroids, which can produce challenges if a person has a transportation issue or if a person is working and cannot afford to take the time off work. We also treat relapses with high-dose oral steroids. The challenge here is tolerability, and also in the United States, I will say that another challenge is the number of pills, because it's a very high number of pills on a daily basis. in this country, we don't make prednisone over a certain milligram, whereas in Canada, they do. So if you're Canadian, you may opt to take some pills. The other challenge with the oral steroids is the length of time that you have to stay on them, and then there's a tapering dose, and so it just exposes your body to the potential side effects for longer than IV steroids. Another option is ACTH, which is adrenocorticotropin hormone. This is a hormone that your adrenal glands manufacture. So it's an endogenous product. When it gets into your body, it stimulates your adrenal glands to make their own steroids. Its trade name is Axar gel, and this can be given under the muscle by a shot or under the skin by a shot. And the challenges for ACTH gel are cost. It's a very expensive therapy, and coverage. Coverage is a challenge because of cost. Administration of the drug is very easy. Most people living with MS at least 10 years ago knew how to give themselves an injection, and this was not a big deal. Now when I speak about ACTH to a room full of people, many of whom are newly diagnosed, and I say, this is great, it's easy to use, you can give it to yourself, you don't have to worry about an infusion center. I see eyes get bigger and bigger and bigger because many people living with MS in the last, 8-9 years have never given themselves a shot for MS. So we also need to teach how to do that. Plasma exchange, which is a procedure usually done in the hospital and involves central line placement, is used for severe relapses or relapses that seem to be getting worse and worse and not responding usually to IV steroids. And then IV immune globulin is infrequently used for relapse treatment, again, if these other things have failed. I do think it's important to mention that we usually reserve ACTH for a person who has tried and failed IV steroids, had a very significant adverse event from them, or has significant issues with IV access. So we do have options for treatment. These I'm going to call them steroidogenic treatments, IV steroids, oral steroids, and ACTH gel are usually well tolerated, but they do have side effects and adverse events. The adverse events are typically associated with long-term use. They do have reasons not to use them, such as certain medical conditions. A good example would be an active infection. An adverse event would be, say, a significant increase in blood sugar or blood pressure with administration of the drug. And then with long-term use, there's a slew of things that can happen with steroids, which is things like high blood sugar, high blood pressure, obesity, adrenal failure, high cholesterol, cataracts, changes in the joints, particularly the hip joints, like avascular necrosis. And so that's why it's very important to understand the importance between a relapse and a pseudo-relapse so that you can educate yourself that you don't always need steroids to feel better. It's important that your MS provider knows your entire medical history as well as your medications and supplements before prescribing steroid treatment. Pseudo-relapse treatment, from a pharmacologic standpoint, includes treatment of the underlying condition. And that might be antibiotics if there's an infection. It might be heat exposure that's caused a flare of symptoms. And so one might use cooling or rest. rest for overwhelming fatigue, and mental rest for stress. There's much more that goes into treating relapses and pseudo-relapses than just making them go away fast, because both of them are associated with an increase in symptoms. Symptom management occurs best with an interdisciplinary team of people all working together to help improve your outcomes, your health outcomes, and your quality of life. Your medicine team would be your physician or PA or nurse practitioner that may make adjustments in your symptomatic medications during the period of time that you're having either new symptoms or worsening of old symptoms, and would also give you referrals to new specialists that you might need to help manage these symptoms and help you get better. A good MS nurse in your clinic would help you with counseling, navigating the systems that you need to navigate, prioritizing the most important parts of your treatment plan, and also helping you get to the referrals that you need as quickly as possible. I would also add here, though it's not on the slide, that a social worker in a clinic can help with some of these things as well. The rehabilitation team is so important in symptom management if symptoms are increasing, because this increase in symptom may affect your ability to move, to feel, to balance, to see, to concentrate, to multitask, ultimately to do your activities of daily living and perhaps even your job. So referrals to physical therapy, occupational therapy, and speech therapy may be needed. And then mental health. Management, I think, is very appropriate when people are fearful, when they're worried, when they're concerned about a loss of control or about a change that may have occurred that is permanent. And might result in a change in role, either at home or in the workplace. So your rehab team consists of physical therapists, occupational therapists, and speech therapists. Physical therapists help develop plans to improve your strength, your movement, your pain, and your balance that may have been affected. They use physical techniques like exercise, stretching, manual techniques like massage, ultrasound, TENS, and then also bracing or assistive devices if needed. Occupational therapists help develop plans to make your activities of daily living easier. They help you to use adaptive equipment and improve energy conservation. And you might say, well, what does that mean? So an occupational therapist could help you with navigating meal planning around your kitchen so that you're not getting up from a stool 1,600 times to gather all the things that you need to make a meal. They might help you with doing similar techniques when you're getting ready for bed at night. And then a speech therapist would develop a plan if there were problems with speech or swallowing. So how about relapse outcomes? Two things that I hear from people living with MS that bother them about relapses are, one, this disease is unpredictable and I don't know what's going to happen to me tomorrow. And two, how do I know if I have a relapse that I'm going to get better or get worse after the relapse? So the bottom line is that relapses suggest active MS. So if you're on a disease-modifying therapy, it suggests that perhaps that drug may not be potent enough for you or may not be the right mechanism of action for you, depending on when your last relapse was. They indicate new areas of inflammation in the brain or spinal cord. And most people have complete recovery of relapses, especially early in relapsing MS. However, as the disease goes on and we lose reserve in the brain, then it becomes harder to have complete recovery of relapses. So people will say, well, what if my relapse symptoms stay? If you're early in your MS journey and you have incomplete recovery of relapse, that is a poor prognostic sign, which unfortunately means we suspect that you have the type of MS that might cause more symptoms and more problems for you. Relapse symptoms may take a few months to completely resolve. I never give up hope on a person when it's only been 4 weeks since a relapse. I typically look at 3 to 6 months as a good benchmark. And I also look at what else is going on in the person's life that may be offensive to their central nervous system. And then as MS progresses, your level of disability may increase after relapse just because of that lack of reserve in the central nervous system. So once we turn 30, I hate to say this because I'm now way, way older than 30, our brains start to get smaller yearly. And when you have MS, that brain atrophy occurs at a more rapid rate. So the brain is less able to catch up after an insult like a relapse, which is why with age, you may develop more disability after a relapse. So let's talk about your relapse toolkit. I like to give people tools that make them feel empowered and make them feel like they have the ability to control what's going on in their lives. So think about these questions. Have you had a relapse before? If you had treatment for it, did it help you and did you tolerate it? If not, then before you have another relapse, you should talk to your provider about what your next options would be, because that will help you make a decision when the heat is on, rather than having to learn new information when you're in a state of stress. If you're currently working, do you have the appropriate securities in place in case of relapse? And the webinar about challenges at work with relapse would be a good one to review. As far as information that I can give you in this webinar, what I would say is consider having FMLA paperwork filled out. And if it's in your budget, having short-term and long-term disability plans that can assist you if need be. Also, do you see your MS provider regularly for appointments to assess your relapse rate, how many have you had, and what period of time, your MRI, has there been any changes, and your disability progression? If you're currently working, as I said, you would want your MS provider to complete FMLA, which stands for the Family Medical Leave Act, paperwork so that you can use it if you need it, rather than frantically trying to get it filled out when you're already upset and anxious and have things to do because of this relapse or this pseudo-relapse. Talk to your employer, like I said, about short and long-term disability plans. The costs of these vary. Many times they're taken out pre-tax, and there are levels of plan that you can decide based on the percentage of your salary that you wish to choose. It's important to plan. So think of it as an investment that can decrease anxiety if you face the challenges of needing time off for a relapse or pseudo-relapse to recover. And then you just write all this stuff down on a piece of paper, or in your smartphone or on your iPad and tuck it away and make sure you know where to find it if and when you need it. The hope is that you don't need it. So what about what to do after a relapse? A relapse is a sign for you and your MS provider that your disease-modifying therapy is not controlling your MS. And it's also a sign for you and your support partners that you should look at lifestyle factors and self-care practices that could improve your life with MS. And those lifestyle factors are things like well-being and mental health. Are you managing your stress level okay? Are you saying yes to too many things? Might you need some help ironing out what's most important in your life and letting go of some things that are no longer serving you? Also, nutrition. Are you following a healthy, well-balanced diet that fuels your body? And exercise. And I'm not even so sure I'm fond of the word exercise anymore. I like to talk more about movement because I think that sometimes exercise is a term that is perhaps like diet. I prefer to talk about nutrition as fuel and movement as something that can be joyful and not something we need to beat ourselves up about if we don't get it done every day. So movement, picking an activity that you like to do to move your body on a daily basis. Make a follow-up appointment with your MS provider if you've had a relapse or a pseudo-relapse. So I think it's very important that within, say, 1 to 6 weeks of having a relapse, you do see your MS provider so you can talk about these things, like reviewing your relapse history, your last MRI, disability progression, and any symptom changes. And then you and your provider can discuss whether or not you feel you are on the appropriate disease-modifying therapy. I also suggest making an appointment with your primary care provider to discuss other medical issues that may have been affected by the relapse or the relapse treatment, such as blood pressure, blood sugar, cholesterol, swelling, or mild weight gain that's usually transient. Develop a plan together with your healthcare team that's one you are willing to follow. If someone develops a plan for you and you take a look at it on paper and you say, well, that sounds great, but there's no way that's going to work into my life, then what good is that plan for helping you? So it's important that you have input into your healthcare plan. MS requires an interdependent, collaborative, varied team. No significant task can be completed or accomplished without the help and coordination of every team member. Members typically specialize in different tasks, and the success of every individual is ultimately bound to the success of the whole team. No team member has ever won alone. I like that last quote because what I hear from people is that, gosh, I don't want to see another specialist. I don't want to see another doctor. I don't want to go to physical therapy again. Can't you just do that? And no, the answer is no. We can't do it by ourselves. Our areas of expertise are in different areas. And so utilizing each member of the healthcare team to your benefit will ultimately result in a better outcome. And we have good research to tell us that, actually. So these are all the potential members of your healthcare team. And in your journey with MS, you may or may not see all of these people. I'll talk about the urologist as a team member. People who have frequent UTIs are often asked to go to the urologist, and it's never really a pleasant thing, and it's not necessarily the doctor that is your favorite day on your planner. But urologists are very helpful to determine what type of bladder dysfunction you have, what types of medications or procedures may be the best for you. And if you have an issue with frequent urinary tract infections, it's better to have a urologist on your team just as a member, call it special teams like football, than to need one when you really need one and not be able to get an appointment for 3 months. And you may really need one if you have a urinary tract infection and the bug or the bacteria is something that's resistant to most common antibiotics, or if, what you've been doing for your bladder all this time suddenly isn't working. So that's just an example of saying okay to adding a team member, but not necessarily having to access their knowledge all the time. Your MS team can look overwhelming, but like I said, you don't need all the special teams all the time, and it's better to have them trained when you need them. I'm sure most of you have had the opportunity to call a specialist that you really needed to see like yesterday and be told that since you're a new patient, the next new patient appointment isn't for 6 months. And that certainly only adds to the anxiety of having an unpredictable condition like multiple sclerosis. So let's get you guys ready, not worried. So this is just an overview of some of the things that keep you ready. And if we start at the top left and go clockwise, then we're looking at a nutritious, healthy diet that is full of green leafy vegetables, colorful fruits, whole grains, if you tolerate them, that's high in omega-3 fatty acids, and free of processed foods, processed sugars, just fuel for your body. Exercise or movement on a daily basis. It's recommended that we move our bodies 150 minutes per week, which it translates to about 22 minutes per day. So whether that be gardening, stretching, cycling, walking, yoga, tai chi, dancing, your care partner, your support partner, moving your limbs for you, moving your body is what's most important. Practicing stress management and mindfulness. So I really love this little cartoon. Is your mind full? Like full, it's just always going, you can't turn it off? Or are you being mindful? Meaning, are you taking some time to empty your brain, to create space for peace and calm and joy in your life? Do you have a community? Do you have a team of people who you can count on when you need support? Do you feel like you are a part of something bigger than yourself so that you don't feel alone when a challenge like a relapse or a pseudo-relapse happens? And then your healthcare team. So your healthcare team having in place the things we talked about, like relapse treatment options, having the team members that you might need to help you recover from a relapse or a pseudo-relapse. I think the most important ones beyond your MS provider are probably the relapse team and the mental health team, and knowing what your toolkit is if and when this occurs. I have a safe and I keep stuff in it, passports, birth certificates, baptismal certificates, my grandmother's pearls, those sorts of things. And I go into that safe, I don't know, maybe a few times a year. But it sure makes me feel good to know that all that stuff is tucked away where I need it. So I would encourage you to tuck away the information that you need to be armed with a plan if and when a relapse occurs, so that you can be ready to take it head on that you can be empowered to know that you have the information that you need to get through this challenge. And with that, I will pass the slides back to Laura for questions and answers. And I thank you guys for your attention.
Fantastic. Thank you so much, Megan, for answering so many questions about relapses. We do have some more questions from our audience. And so the first question I would like to ask you, you talked a tremendous amount about the healthcare team, which is so important. But how do you create a team when your specialists do not interact with each other?
That's a really great question. And I think it's sad, and unfortunately it's sad reality. So the electronic medical record was supposed to make it easier for us to interact with one another, but I think all it did was make us much less likely to pick up the phone and call one another. So if that's the case, and if it's something that you really struggle with, I would encourage you to take matters into your own hands and ask for an office note from each provider as you're leaving their office or after you leave their office, so that you can have your medical records with you. And that way, when your neurologist or your MS nurse practitioner or PA says, hey, what did the urologist say, or what did the orthopedic say, you're not responsible for trying to remember the medical terminology that's important to us. So that would be my best solution for that.
Great. Sort of keeping along that same line, I think that is great advice. One of the questions we had was about going to the emergency room and how to inform an emergency room physician who doesn't really have experience with MS and or relapses. So would that be something that you would give as advice to prevent, to arm themselves when they go to the ER?
Yeah, I think if you're going to the ER with a relapse, it's probably most important for you to have your medication list, your list of providers, and to know when your last MRI was, and if it's not in the same hospital system, to bring that CD with you, so that if you're going to have an MRI from the emergency room, a radiologist would have something to compare it to. I don't want to tell you that ER physicians or ER providers are going to take or have the time to review extensive medical records, and that's why I say, bringing all that stuff with you to the ER is fine, but the most likely things to get reviewed are an MRI CD and your medication list.
Okay, terrific. You brought up the MRI, and we did get a number of questions about the MRI and how frequently one should get an MRI.
Absolutely. So for people with relapsing disease, it's recommended that they have annual MRIs, and reasons for having them more frequently would be related to the type of disease or the disease modifying therapy that you're taking. For example, more frequent MRIs if you've been on natalizumab or Tysabri longer. More frequent MRIs if you have had a disease-modifying therapy change, particularly if your disease-modifying therapy has changed because of breakthrough disease, then your provider may want an MRI in 6 months after that change was made instead of waiting 12. Reasons why you may wait longer between MRIs would be that you've been very stable for many, many years without new lesions, without relapses, without disability progression. And then you may have a conversation with your MS provider about the necessity of having a yearly MRI.
Okay, terrific. We also got a couple of questions about symptoms that precipitate a relapse. Are there symptoms that do precipitate a relapse?
I don't think so. I think, relapses are different for everyone. There has been differing opinions in the literature about whether or not severe infection or very significant psychological stress can precipitate a relapse. And again, the jury's kind of out on that. There has been data that looks at very significant psychological stress as being associated with gadolinium enhancing lesions in MS. But as far as, can you tell a relapse is coming on? I think that's probably a very individualized question.
Okay. And going, into a vocabulary type question, is a relapse the same thing as a flare-up?
So sure. And I apologize. I should have maybe listed all the things that they could be called early on, but people will call relapses, flares, exacerbations. Those are all synonyms for one another. It can become complicated when a person says, oh, yesterday my symptoms really flared. So that doesn't mean that they had a relapse. It just means they were having one of those bad days. But people call relapses by many different names.
Okay. So, and would you say that nerve pain is commonly associated with the relapse, or is that more associated with the pseudo-relapse?
It depends on the onset of the nerve pain and how long it lasts. So if you have nerve pain in a part of your body or in a limb and you've never had it before and it lasts for more than 24 hours and it's not related to something else, then chances are it's a relapse. If you have nerve pain that comes and goes in a limb or a part of your body as you have good days and bad days, and it's worse for a few days, then it could be a relapse, or it could be that, you're dealing with something else like fatigue, heat exposure, and infection, and thus it would be a pseudo-relapse. So I think it just depends on whether it's old or new and how long it's sticking around.
Okay. And I know you've touched on stress quite a bit and how it affects relapses, but we did get a number of questions. So can you kind of review stress and what role it plays in relapses?
Sure. So the literature, the scientific literature, is inconclusive about whether or not stress can definitely cause a relapse. A relapse being a new inflammatory lesion in the brain, an enhancing lesion in the brain that's associated with a new symptom. There is one study that suggests that very significant psychological stressors, such as severe psychological trauma, are associated with gadolinium enhancing lesions, so new MS lesions. It's much more likely that chronic stress over time could lead to, or even say an acute stressor that leads you to make poor lifestyle choices like not sleep, eat poorly, drink too much alcohol, forget to drink water, could cause a pseudo-relapse. So it's more likely that that stressors like those things are going to cause pseudo-relapses to happen. In general, though, stress, anxiety, depression, those types of problems in MS are associated with people feeling more poorly, feeling more fatigued, feeling more pain. And so that's why we really harp on stress management as a platform of managing wellness in your life with MS.
So we talked a lot about tools for your toolbox, and I did get a question about how to improve your energy level during a relapse. So can you talk about some tips or some suggestions that you might have?
How to improve your energy level during a relapse? Yes. I think that the two most important things are to rest and to stay hydrated, so drink water. Especially when you are using a steroidogenic treatment. You really need to flush your body. It's likely that you're not going to be moving as much if you've had a relapse in that acute period of time. Many people try to push through these relapses, and they find that it takes longer to recover, or they worry that they're not going to be better because the symptoms last longer. So I think rest and hydration are very, very important to improve your energy level when you have a relapse. I don't think that, that there's a medication that would particularly help you during that period. I will say that many people do realize a nice little bump in energy from steroids, but for other people, steroids make them feel kind of tired and yucky.
So is there a way to tell when a relapse is over? Some people indicated that they're not really sure.
Yeah. So a relapse would be over if your symptoms are completely resolved within a period of time. And for most people who receive a treatment like IV steroids, their symptoms are going to be resolved within about 2 to 6 weeks. If your symptoms have not resolved in that time period, many MS providers would give you another course of treatment to see if you can make a little bit more headway with a second course of treatment. If you're getting into the 3 to 6 month mark and you still have some symptoms of relapse and you've gone through physical therapy and occupational therapy, then it's likely that you will not have complete recovery from that relapse.
So we didn't talk at all today about pregnancy and childbirth, but is there typically an increase of symptoms after childbirth? Is that typically considered a relapse?
So the good news is that only about 25% of people will have a relapse immediately after childbirth. I think women hear these statistics about postpartum relapse, within the first 3 months, and it leaves them very fearful. But the reality is that the majority of people do not have a relapse after they give birth. Things that are associated with better outcome after delivery are stability of MS before you got pregnant, use of disease-modifying therapy before you got pregnant. And so if you're in that category of person, then your likelihood for relapse in that postpartum period is fairly low. And again, only about a quarter of people will have a relapse after pregnancy. If after pregnancy, before you were to restart a disease-modifying therapy, you have a new symptom that you haven't had before, then that could indicate a relapse. If you're finding that you're having more mediocre or bad days from old symptoms that used to visit you, then indeed it could very much be related to fatigue and poor sleep and, the new life that goes on with being a new mother. So, both of those things are manageable and deserve a phone call or an office visit so that you can be the best mom you can.
Great. Kind of staying along that same line, do menopause and hormonal changes affect your chance of getting a relapse?
That's a great question. So your chance of getting a relapse is not affected by menopause. However, women going through menopause often report an increase in symptom severity. So fatigue is more fatiguing. Tingling is more tingly. And that's probably hormonally generated. It could also be related to the effects of hormones like hot flashes. But that does not mean that you're at greater risk for relapse.
Great. I think that that's all the time we have for questions at this point. Megan, is there any other closing statements you want to make about relapses and what people can do to to live better with MS and prevent or just take preventative measures?
Yeah, Laura, I think the best thing I can tell people is that, really the power to manage your health lies in your hands. And if you feel like it doesn't, then I'd encourage you to take it back. And by doing that, I mean, having a chat with your MS provider about what to do should a relapse occur. If you don't understand what a nutritious diet is, review one of the Can-Do webinars that excellent nutritionists give. But really just arming yourself with the resources that you need, having your medical records, arming yourself with the resources that you need so that you can feel empowered and not at the mercy of other people who may not always work the way you want them to, if that makes sense. But I do think being prepared in the case of a relapse is a better way to be than having to be more worried when and if one should occur because you're not prepared.
Great. Thank you so much, Megan. This has been a truly informative webinar, and I think we answered a lot of questions that are out there.
Great. I hope so.
Terrific. And again, thank you so much for your time. As we conclude, I would like to inform you of some additional resources that you may find informative and helpful. As Megan said, on the Can-Do MS website, can-do-ms.org, you're going to find all of our archived webinars, our e-news, our library articles, and Can-Do On Demand. You can also submit a question to the Ask the Can-Do team, which will be answered by our team of MS experts. Now, this webinar is supported by 3 podcasts. So Megan mentioned those during the webinar, and they are podcasts, and they focus on everyday challenges that relapse can pose at home, work, and in relationships, along with practical tools and strategies for meeting these challenges. So if you're interested in listening to the podcast, you can find a link to them on our website. Our sponsor tonight, which is Mallinckrodt, so I want to thank them for sponsoring this webinar. And so thank you so much for participating in tonight's webinar. Have a wonderful evening.